So,
Is it yours? Thank you. But we can't. So you just
how are you going, Aisha?
love a cherry.
I'm very well, thank you. How are you going?
One of my favourites.
Okay.
Brilliant. That's pretty good. Yeah, I think.
Gorgeous. Did you get them?
Blinking peak. Let me know if you're on the road.
Thank you. Okay. All right, welcome back, everybody. We now move on to the next part of our structured agenda, which is around key service areas challenges. So this covers hospital and specialist services, primary and community care, mental health, and other output and service areas like public health and Holder Māori services. Do any members have questions? I'd hate to move on to the next section.
Yes,
Sorry.
I could ask a question.
Dr. Verrill.
Can pick up the point about primary and community care. What efforts have been made to quantify the vacancies in the workforce gaps in the primary and community parts of the sector?
Thank you for that question. There's a number of areas that we're working through, mainly in the primary community through the Primary Care Tactical Action Plan, which is looking at the additional 400 nurses into primary care, 100 NZ, additional NZ docs by October next year. That's starting the training program from now until October next year. We have the 50 New Zealand trained doctors pathway that's being worked on at the moment to start through next year. Also, the additional training for nurse practitioners and advanced training for nurses within primary care.
Clementary, where is the Primary Care Tactical Action Plan published? And why does your webpage say it's under construction when it has been repeatedly referenced in Ministerial and Health New Zealand comment?
Oh, apologies, I'll have to look at that for you, and we can get that up on the website.
That would be fantastic, because I did search extensively for it. So perhaps, given that it's the subject of so much discussion and yet not published, could you tell us what's in it?
Oh, sure. So we have places for 400 new grad nurses within primary care. There is 100 New Zealand trained, New Zealand NZREX doctors, places to start over the next 18 months. That's starting their training. There's an additional 50 New Zealand new grad doctor pathway. That's to sort of start next year. We have 180 advanced nurse training positions plus 120 nurse practitioner training position, or for nurses to work through their nurse practitioner qualifications.
Is the Primary Care Tactical Action Plan only about workforce, or also about how care is delivered in the primary and community sector?
So it's also got further components. So under the whole action plan, there's a component on workforce, and then the additional rollout of the urgent after hours over the next 2 years. That's included under that as well.
Medicine.
Oh, the medicine.
Prescribing.
Oh, sorry, the 12-month prescribing. So the additional 12-month change into the prescribing.
Okay. The relativities in pay between the hospital and the community sector, it's argued that the lower rates of pay in parts of the community sector makes it harder to fill vacancies. Is there any work on pay parity underway by the government?
I can't make a comment on the government, but as Dr. Bramley made the point previously around funding into the primary care sector, it has been a priority in this round of funding going out. As it's been mentioned, it's been the highest increase over the last number of years going into into general practice, as an uplift recognising the importance of the sector.
Dr. Bramley, previously you mentioned alliancing. Can you please explain what alliancing is and what the value you see in it for the health system?
Yes, sure. So what I'm particularly keen to have restored is and it's not lost in every place, by the way, so, is the relationships, collegiality, the way of bringing both primary and hospital doctors together in a systematic way to focus on joint priorities, and then also at a very basic level for people to get to know each other as well. And when we've seen that working previously in the past, it has very much been about if you're a GP, who do you refer to? And if you're the receiver, knowing your colleagues in primary care, but then also what are the issues that might be affecting that flow of information or the flow of patients or clinical issues, and then creating forums that are based around the concentration of the referring pathways, which is usually the hospital as the bedrock of that with its primary care practices as well, and creating the ability to network and bring those things together in a very organised way up and down the country. Dr. Sullivan is overseeing, do you want to come forward, that work program as we develop that up. Do you want to add, Richard?
Yeah, so as Dale's mentioned, we're sort of working with sort of primary care clinicians about joint terms of reference across the country, because it's an opportunity not only to build relationships, but equally to look at those kind of key, I guess, areas of tension and that may require investment. And so that as a provider, we can kind of understand that health pathways, which you're possibly aware of, which is that kind of primary care pathway into secondary care. So a lot of that stuff, as Dale mentioned, used to exist back in the world of DHBs, and it variably exists now. So some places have held on to those relationships, but many have let them drift. And so wanting to get some consistency back, but equally, the opportunity to have a joint kind of, what is the purpose of these groups and how they're going to really function, how they're going to make a difference to the health system.
So my other supplementaries are directed at trying to understand what this concept can actually assist with. Is it, we hear on this committee a lot about the opportunities of new models of care, of moving care out of the hospital into the community. Are they a vehicle for achieving that change or not?
This is the discussion we're having around the terms of reference. So some of the things can be really, I say simple, they're not simple. So for instance, someone orders a blood test, who's responsible for that blood test? When it gets sent out, the patient goes back to the community, is the ordering clinician from the hospital responsible, or is it the primary care practitioner? And so we've done a lot of work trying to get a sort of standard protocols and policies around areas like that. But we absolutely see the opportunity, to your point, around the shifting of models. Now that's also a clinical network opportunity as well. So there's clinical networks which also have primary care members on them, is looking at the different ways you can deliver services. So, but we're still, I guess, aren't solving that question you're asking.
I've got
a bunch of others.
I've got others. Yeah, cool.
Yeah.
I'll come back
Can
to
I
you.
just directly on,
Oh, well, I'm stopping on that too.
but
Go
specifically
Jenny,
the,
and then to you, Hamish.
Thank you.
She was on there first.
Recently, the Minister announced a primary care advisory group. How do you think that group will help with the program of work you've got with primary care?
Yes, I can answer this. I think the question, look, the Minister's looking about how do we work closer with the primary care and the clinical frontline positions within the sector. So that's one mechanism to have discussions through that network. We work heavily along other networks that are all GP networks and our PHOs in a number of areas to improve our models of care, work with them about the integration of our services. Alliancing is one of those frameworks where they're clinical alliancing, and then we have the wider alliancing, which is about, can we look at referral pathways, can we look at hospital avoidance or hospital discharge, but that also incorporates larger components of the sector, so our home-based, our ARC, for example, age residential care.
I have further such, but I can take them later.
Hamish.
is it, are you looking at models, something like the community rehabilitation enablement and support team that we had probably in Christchurch, the CREST model, to look at kind of more widely across rehabilitation rather than maybe clinical networks, which I know there's been a number of pathways, including COPD. Are you looking more widely at kind of the integration of primary health care with our hospitals?
Oh, look, absolutely. So the CREST model, and there's a START model in the Waikato as well. So they're very similar about rehab approaches. They're aimed at how do we do supported discharge, so how do we get patients out into our communities or into aged residential care as quick as we can in a seamless way. Also about how do we support people in their own homes around allied health and other work programs or supportive mechanisms in those models of care. So absolutely, it's one of the work programs our primary community teams or planning and funding teams through the regions are working together around those models of care, looking at case mix models of implementation and home-based. Because what we've seen over the years is the acuity of those people living in their homes has risen. We need to adapt our models of care to support those.
Can I add to that, which is not necessarily directly at the primary care, but the kind of the models question. So we're looking quite a lot of, I guess, alternative workforce solutions. So audiologists undertaking first specialist appointments now. We're doing that initially in a secondary care kind of setting, but you could see how you could take that into primary care over time. Dr. Connolly mentioned earlier the work we've done with the ophthalmologists and the optometrists around the follow-up of post-cataract surgery. We're also doing the same with orthoptists around squints for our children to look at how that model could look. And then the other area, which we think is a huge opportunity, but work to do, is around what we call the musculoskeletal pathway. So people who have back pain, hip pain, shoulder pain, what is the model in that space, and use advanced physios. Again, at the moment, we're looking at that very much through a secondary care lens, but the intention is to then take that into a primary care setting.
Excellent. Okay, Dr. Vera.
I just noticed in those answers that it's not certain that the model of care work would necessarily be part of the alliancing. It might be focused more on a more narrow focus on relationships. So notice that was your previous answer, and that in the you've also cast forward to what could be achieved. Our committee will hear from you next year and the year after. What is a realistic expectation in terms of seeing these models of care, the opportunities by new models of care actually being delivered in terms of how many years out and the scale of what's achievable? This was one of the big promises of the reform. It's really enabled by technology. Everyone wants to do it.
Yeah, no, great question, and something that we discuss and debate a lot, as you could imagine. If I take the ophthalmology pathway as an example, so we have actually, this is getting into detail, but historically, I think it's about 23,000 patients would have cataract surgery per year. All of those patients who are being, contacted the day after their surgery and then a month later being seen by specialists. The day one follow-up now doesn't happen. The patient's given an SOS, so a phone number to call if they've got concerns. That's for about 60% of people who have that cataract surgery. So 40% still need to be seen because it's more complicated surgery, and this has been a very clinically led piece of work. And then the 1 month follow-up. So we're just in the process now of looking to contract that into community. So we're doing that as we speak. And we've agreed on the orthoptist pathway. So that's, again, a clinically led piece of work. So in a year's time, I think we could confidently say we've implemented the ophthalmology pathway, and actually what that does, and it'll be interesting to see, what the number lands, but we're predicting between 2.3 to 2.5 thousand extra FSAs will be achieved by this model. So our specialists will be able to see another 2,000 to 2,500 extra patients because of the shift in model. So I think some of those things we should be able to come back to you and say, yes, that has worked. The MSK, we've recently appointed, or in fact, we're about to complete the appointment of 17.6 FTE advanced physios into the system. So again, the shift to model, we're capturing that data regularly, so we should be able to feed that information back to you as well.
The promise is so great, that's a great example what you've given, and yet the need is so high because there's people aren't getting the care they need on time. There's unmet need in the community, and the emergency departments are overcrowded. You know the problem. So shouldn't we take all of these opportunities? How do you get to a point? What do you need to get to a point where the scale of these types of changes are enough to impact the big problems we have in the health system?
Yeah, so look, all of the things to your point that I'm talking about are small increments rather than massive, scale change. We are exploring what we're calling regional hubs, so they're kind of an opportunity for people to refer into. We're looking at what we're moving to what we call clinical utilisation criteria. So we historically, and so this is kind of, hopefully I'll try to make this make sense, but we used to use what's called CPAC scoring. We still do use CPAC scoring in a lot of our systems.
My question is more about the scale of this type of change, and are you constrained by the number of management bandwidth or budget or technology? Why can't we do even more of this great stuff?
I think my honest answer to that would be clinical change is tough. So making sure that it's clinically safe, you've got the right quality systems around it, and that the clinicians shifting from respectfully a kind of a doctor-driven model to a sort of a more interprofessional-driven model takes time. So I think there's some real constraints in that space. Look, I think change is hard in the health system. I think there's always an opportunity for more change investment where the change is going to make a difference.
But the hardness is currently falling just on the eye folk, so to speak, and then there's a whole slew of other specialties and patient groups waiting for that investment and modernisation of their systems as well.
So I would supplement that by saying that if you find the right innovation that is responding to a really significant need, I've been very surprised at the speed of the uptake. So when it comes to a very traditional model and changing that from FSAs to alternative workforce, then you need to have the other workforce ready. You need the clinical support for the change in the model, and that can take significant time. On the other hand, I mentioned the uptake of these ambient scribes, the tools in ED, where we've had exactly the opposite issue. Flutter requests, and now we have thousands of people wanting to use that all in the space of months. What I've launched is a project called HealthX, which is trying to identify those innovations that we're not inventing, that might be in some other system already up and being used, and is there an opportunity for rapid adoption of those, because they're already clinically tested and we know they work. So coming into that suite, the one we're working on at the moment is, for example, up titration of congestive heart failure meds using technology monitoring in people's home instead of needing to be done in health facilities. That looks like it's going to have rapid uptake. Same with the use of some AI tools in radiology, where a number of radiologists are already using those. Then it becomes, how can we enable a more rapid uptake of a change in practice that is occurring? So that HealthX program we're sponsoring is trying to say, what does that look like? Already underway, or who's doing what overseas? And we've made contact too with the NHS because many health systems are thinking about this exact same issue. And so we've asked them if they will share with us what they have done, and they've very generously shared some of that with us, and trying to create connections so we can see those things which are moving inside public health systems already, and then can we adopt them? Because I think if you pick the right thing, then it's us sort of accelerating it rather than trying to be the lead of the model change. We then become the sort of a supporter of the change. Yep. So I think there's a bit of a dynamic about both those things going on at the same time.
Thank you. Two more supplementaries to clarify this further. What is the Alliance as a structure, and how does it relate to the existing PHO structure? And
Yeah, look, I think alliances take a wider view. So we have the PHOs as a mechanism that we work with around general practice. Alliancing does go a wee bit further. We would like to include our pharmacy partners, our home-based, our ARC partners. So then we're looking at this system. I think to your point about how quickly and how can we move our services and models of care forward, we do need to take them bite-sized at one. Because every time you touch one part of the sector, as you know, in health, you can have causal effects or unintended consequences in another part. So our role through those alliancing frameworks, working with each of our sectors, is to ensure when we make a decision or a change to model of care, we don't have unintended consequences either to our hospitals or from our hospitals back into our primary. And that's a network I see sort of delivering those types of conversations and models.
Okay, so it sounds like a comprehensive primary care
Yes.
network is what the alliance is. So then what is the relationship between the Iwi Māori Partnership Board and the alliance?
Oh, look, I'd see them as a key partner in anything we do in our communities. The communities are sort of the fundamental to the models of care. They're the voice we need to hear from to make sure it's working, and bring those voices through into alliancing frameworks. And Salah might be able to touch a bit later on those as well as part of your IMPBs.
To be just, you're still clarifying the scope of your work.
Yes, correct. Yes.
Okay.
Yeah.
Thank
I
you.
think, sorry, just add to, I think, to Dr. Bramley's comment before, we used to have these in place and we've lost some of these connections. We need to learn from how those worked previously, and what we're starting to do now, what we're starting to do now is bring those back into place over the next 12 months.
Primary, Hamish Campbell.
Excellent, brilliant. Can you give us an update on the new urgent and after hour care services?
Yes, so as announced by the Minister, we've got around 70 locations over the next 2 years to roll out. And there's a planned rollout of each of those sites over that 2 years. We're on track to deliver those. Probably one of the things we need to work through over the next 2 years, the workforce issues that we've previously talked to, is as those sites are either extended in hours during the day or extending the days they provide those services throughout the different rural and urban locations in New Zealand. We just need to be working with those areas, with those practices and other services that support them, like St. John's, for an example, about how do those workforces and how do we extend those hours or weekdays.
And I think in one of the previous answers, it was said that there's been a 4 to 5% increase in our presentations in the ED department, and that's continuing to increase. Do you see this as a way to actually reduce the pressure on our EDs around the country?
Yeah, look, absolutely. Along with the 24/7 digital service as well that was released in July, we're seeing that uptake of about 45,000 people have used that service since we sort of soft launched that at the beginning of July this year. We see that as a tool alongside face-to-face services to take those pressures off our ED services, ED departments.
Yeah. Would you also see those digital services taking off pressure off some GP practices? Do you have any information on the share of GP practices that are open to new patients?
Look, we're seeing, so just the first question, absolutely. We see the 24/7 as a complementary service to our GPs. Our main goal is to have our population enrolled in GP practices. But we know, depending on where you live, rural, urban, that sometimes it is difficult to either get those appointments or in a timely manner. The 24/7 provides an alternate option, and we've seen that type of uptake for the reasoning of using the service. And what we are seeing is start to see a slight uptick in general practices with open box. It is slight, but it's positive in the sense we are starting to see more general practices with open box.
Just supplementary, do you think the biggest barrier to GP practices being able to take on more patients is not actually the number of GP practices, rather actually a workforce issue?
Yeah, absolutely. I think where we see pressure points in communities, it'll be out the workforce, rural communities, urban communities, is a workforce issue.
Yes, thank you.
Right.
Supplementary.
Supplementary, Ricardo.
I think
What feedback have you received from GP-owned clinics in relationship to potential changes in ownership models and whether those could impact connections to the community or delivery of service?
Look, like all of our funded sector, we work in an environment where we contract with the private sector and they have different operating models and different ownership models. We have guardrails in the way we contract, working through, for example, general practice through the PHOs or directly with GP practices. So our role is to work with the sector and just ensure that the services that we need for the general practice or the PHOs to provide, that they're providing to our communities. But we need to do that with all of our funded sector partners, pharmacy, aged care, home-based. So our role is to work with all sorts of ownership.
But in terms of feedback that you've received, I mean, from, say, GP-owned clinics, like, are there any concerns that have been expressed around the changing makeup of ownership of primary care?
I haven't had any direct feedback from a GP practice directly, no.
Hamish, start.
Hang on,
Pick up on that.
You do too. So I've got Jenny first.
Thank you. Just
Hamish.
supplementary on that. I think you're talking to corporatisation model of primary care.
Indeed.
Have you any concerns that could develop into international companies wanting to buy our general practice, and what are the regulatory barriers that would stop that or enable that?
In relation to concerns, just coming back to my point, we contract now with a range of community providers with different ownership models, different structures, public, private sort of entity. So as I said, I just come back to our core role as Health New Zealand is to work with those providers and ensure that they're providing services to the communities for which we are funding them for and for which they should be providing to those communities. And the guardrails and the contracting frameworks we have, monitoring frameworks, but they're also partners. I mean, one of the things we need to look in the funded sector around our community and our hospitals is we need to work with our providers for our communities because we want services closer to home. We want to be able to provide them in a way that people can access those easily. Obviously, there's constraints of which we can do that. But the models of ownership, we sort of work with the providers and the services for which we need them to provide.
So I was speaking particularly about an international company wanting to come into New Zealand, maybe a private equity firm or something like that, where there are regulatory barriers. That's what I was asking. Do you have any concerns around that?
Look, the honest one, don't have a formed opinion on the overseas purchasing of those. We know we have them through our laboratory providers now. We work with those lab providers that have different operating models or different ownership models. So we have that in the market now. We have that as in our funded sector, and we work with them around, as I said, those services that we need to purchase and want them to provide.
I think where we would have concern is if we saw clinical outcomes being affected, or if we had expectations of service delivery, that those services wouldn't be, and that would be regardless, obviously, of whatever that ownership model was, but we are very much focused on the outcomes and the patient satisfaction as well that would occur with service.
There are a number of corporate providers around now. We know that. Are you seeing better or worsening patient outcomes from those corporate providers?
We're on urgent care, eh?
Primary care.
We have moved a bit.
I think if we look at our annual report around patients' involvement in their care and the satisfaction of that, we are seeing that increasing. The sort of stats that are included in the annual report sort of point to, through general practice, those contacts and patients feeling like they're involved in their care and how they're treated through there is seeing an improvement, which for us goes to the sort of patient-centred environment and clinical outcome.
Perhaps supplementary from Aisha and then Hamish.
Primary about urgent care. Thank you for publishing your urgent acute care after hours care plan on the internet. On page 11, there's this diagram that I believe is trying to communicate that whether you're in a large urban service a provincial city, a rural centre, or remote, you'll have consistent urgent care services elsewhere in the documents. It's within 1 hour of your home. 4 clinical capabilities, radiology access, laboratory, pharmacy, and use of shared care records and notes. Is that vision being delivered by this plan? Is that the goal?
That is the goal.
Did I understand correctly that you said this is a 2-year program of work?
Yes, so over between Jan and June, this 26, 27 and 27, 28.
So and then every one of these places that are within 1 hour of where 98% of New Zealanders live have this level of service.
We'll have a level of service, correct?
Yeah, but there will be a pharmacy available for after hour, for anywhere that there's after hours medical, there'll also be a pharmacy.
Yeah, the model of care will be different depending on where you live, and access to that will be different depending on the location.
And is this plan fully funded?
Yes, it is.
Thank you. Seeing this involved also questions about the provider ownership structure. Could you just return to the comment made by my colleague? Is there any regulatory barriers to a private equity firm buying primary care practices, general practice practices?
Look, I'd have to come back to the committee. I'm not aware of that depth about any regulatory barriers. I'd have to come back to the committee in writing.
Hamish Campbell, so.
Excellent. And I appreciate, Mr. Chair, we might have strayed off the primary question. What role do you see something like community pharmacies playing and taking the pressure off our GPs, with maybe broadening their scope of practice, and what's that looking like? And I suppose, is there any change of funding would be required for such changes?
Look, that's a very good question. So we see community pharmacy as a key enabler to frontline services to our communities. And part of our discussions through our pharmacy negotiation group this year is about how we can expand the services that they provide to our communities. And there are a number of pilots throughout the country at the moment that we can learn from about how they're doing, and we'll use the language minor ailments. So if you go in there for, eyes or throats, that the pharmacy can provide sort of an extended consultation for you. So as I said, there's a number of different service models throughout the country. We're working with our pharmacy networks during this year to look at what additional services they could provide to take pressure off the general practices.
I'd like to...
Can I stop on that? So beyond just pharmacy, obviously, as we get out and about around the community, I've been visiting various general practices.
Yes.
In Kamua, in Whangarei, they have a practice which includes having a paramedic. I've been out to Cannons Creek, they include a paramedic and a social team as well to do that sort of work in the community to get people to come and see their doctor or get their child with IMS or whatever. Those models are the models which I think probably are the future way that primary care needs to work. That's expanded scope. Is that what the kind of model that Health New Zealand is looking at? How do we roll that out, fund that?
Absolutely. And we're running six pilot sites around the country at the moment in some of our remote rural areas. To your point, working with St John's, when the paramedics not out, they're working in the general practice, providing services in there, allied health staff working within practices to provide a wider scope of service. So your point's absolutely correct. We need to look at how our general practices work with additional allied health staff, our paramedics through St John's where appropriate and where available. Our pharmacy providers, exactly that too. How do we get a connected system to provide those services in our communities?
And just a funding question following on from that, how does that, if we're having those kinds of practices with that expanded scope with all those various components in it, how does the capitation model then fit that, or is that the thing that needs to change for the funding?
Yes, absolutely. As we develop these models of care and extended scopes of practice, we'll need to look at how the funding models work. So as any health system around the country, there's two components we need to look at. Those that are don't require money, but we just become more efficient, or we look at models of care and the way we operate and connect those services to be more efficient. And then the funding models that we need to look at and how do we appropriately do that. So this is a non-financial and financial component to anything health does.
Yeah.
And we should always look at both components of those.
Yeah, could I just add that this is really important as this develops, because one of the problems, we're not performing well on ASH rates, ambulatory intensive hospitalisation. So we've got too many people in hospital who shouldn't be there. And if we have these kind of models more ubiquitous in our system, we will be able to do better on ASH rates. And this interprofessional practice is really important in that regard. And that'll in itself take a further pressure off the hospital.
Yeah.
So, I mean, you see from all of these things, they're all interconnected. Yeah.
And it's also bringing point of care testing into some of the general practices as well, in more remote places, so they can do it on site, which is adding so people don't have to travel.
Dr. Farrell.
I'd like to return to the comment that the way you are guarding, that the monitoring of providers is what is the safeguard with corporate providers of primary care services. Can you explain what is measured that gives you that information in general practice?
Yes, so we have a number of clinical indicators which we are measuring regularly and also reporting on. So things like vaccination rates, screening coverage programs, many of which are delivered by primary care, ambulatory sensitive hospitalizations, the ability when people from the various surveys need to access care, are they able to access care? And Jason was just saying, we've just seen it's just gone from a 77.2 to 77.9, which isn't a big jump, but it does mean that access is not deteriorating. And we can also see the numbers of interactions that are going on and where they're going on. And so we can see that across the country. So that's a sort of a measure. We can see very much access measures. Are people able to access these services and are they improving? And then we also get some feedback from surveys such as from the Health Quality and Safety Commission, which talks about the satisfaction that people have with care, including their engagement. Were they happy? Were they involved in decision making? Those sorts of questions.
Thank you. So the point is about particular providers, though. And it could be that you might have a consistent or even improving national average, and there could be a provider that is really underservicing. Do you measure those at the provider level?
Yes, we do measure those at the provider level as well as geographic spread as well. But so if we saw a particular issue with the provider, we would be engaging through the planning and funding team with that provider about what was going on there. And we would view that as part of the regular program management, as it were, of our planning and funding teams with those providers.
Have you ever got to the stage of to what level do you get to with providers when there is underservicing? Are they always able to fix it, or do people lose their ability to get capitation funds?
Well, the simple answer is we have had some issues in recent times with some providers and non-delivery of what we expected those service lines to be. We have engaged with them, and if need be, we have pursued that, especially if we've seen a really significant non-delivery. Jason.
And we're speaking about general practice here.
Providers that might have general practice as part of a wider set of functions sitting within them, and we have pursued that.
Thank you. And if I can continue on, in pharmacy, do you monitor outcomes in pharmacy at all? Because I hear lots about big box pharmacy firms not filling the full script and leaving all the expensive things on the script unfilled. So people have to go to a community pharmacy for that and just do the easy, cheap stuff.
So we have an auditing framework that is done on a risk-based metrics that pharmacies are audited through. So we would act on any time a community member comes to us and indicates that they have concerns or raise questions about a provider. To Dale's point, and our community or regional and local teams through planning and funding would have discussions, and if they had concerns, we can go in and do audits at any stage of any provider.
So the planning and funding team who monitor all these contracts with each pharmacy and with each general practice, where are they located and what size are their teams? Are they regional or district or?
So we have regional teams through the planning and funding. Now they'll be spread within the South Island and Central and Northern and so forth. So I'd have to come back to you on the exact FTE number of each of those teams, but they're based in the region and local districts.
So of the 10 billion primary and community spend, around 8 billion of that is in the regions, and there's 4 regional planning and funding teams, and there's a national one as well. So the national one's also the overall view and does the national negotiations. The things that you mentioned, we'd want to know about that at our planning and funding team, so we could follow those up. And a person can tell us, can come directly to us.
Supplementary
All right.
on primary care, if I may.
What area of primary care? Go on, Jenny.
Thank you. PHOs, if we've got expanded primary care practice, what's going to be the role of the PHOs in that? How will they change as a result? Do we have too many? What's the new world of PHO going to look like?
Oh, look, I think that's still work to be completed, and we're, say, for example, for our conversation, an expanded GP practice, and how do PHOs support that? They're a critical component of the health system and how we operationalise primary care and general practice.
Right, there's funding.
Yeah, through the funding, and they also provide services, so they also support general practice in a number of different ways. That's variable across the country, but they do provide a number of supports through general practice.
Have we got PHOs in the country that are non-performing?
Not.
In Auckland, maybe?
Look, I don't have direct knowledge of underperforming PHOs in Auckland, but our regional teams, if they've got concerns to the conversation we're just referring to, they would be working with PHOs if they had any concerns about performance. And nationally, we would also support that role.
There are some new PHOs being set up, right? Not one in my rohe is Aratake PHO, and yes, it's another, and that's with the corporatisation of primary care. And some of the PHOs have raised concerns around funding will go away from them and then into these corporate models, and that will impact their ability to deliver for their community. Do you think that is a fair concern of the PHOs?
So, I mean, it would go back to that we would want to know the service delivery, the satisfaction with care, the clinical indicators. Were any of those changing, then we would become concerned, because there are, as Jason's saying, already a variety of ownership models. There's also a dimension here about what's policy and what's operational too. So the ministry has a view about capitation, obviously, and they're doing work on the formula, as well as there's work that we need to do with the ministry around this question of the future of PHOs, because that PHOs have been long-standing since the primary care strategy back in the early 2000s, and I think what you can see now is that there is movement of practices as new things form. People are moving. I think there's something in there that we'd want to explore further. Why is that, and what is going on? Because others are not moving. So I think that should be part of an ongoing evolution, that we better understand what general practice, wider primary care see as a useful vehicles for that medium-sized level organisations. And then I think that's something we're very keen to also engage with the ministry on because of their policy function about that. But it's absolutely something that we would like to be thinking about this year, those
Excellent.
things.
Thank you. More subs?
Well, my primary is on PHOs, so if I just get a set of questions on PHOs, then I am happy.
You happy?
Thank you.
Right, good to have
Good. The challenge of making decisions, you have to take decisions about PHO funding once applications to form a new PHO are submitted to you. And yet, as you've discussed, the policy decisions about what the future place of PHOs have not been made. How can you take decisions in that context? And your decisions have the potential to be incredibly disruptive on the architecture of PHOs at the moment. Will you make a moratorium on any further changes until those policy issues are resolved?
So, I mean, we're currently working under the current guidance and policy setting that we have. I think the question is an appropriate question to ask because what we do not want to have happen is unintended consequences of very significant moves. And so part of that is, and that's exactly what I was alluding to in terms of needing to work with the ministry, is to better understand, especially if we had significant movement, what that might do in particular to patient-facing services, which we would not want interrupted, because one of the functions of PHOs is they have a lot of ancillary services that might be attached to the general practice. Maybe ancillary is not the right, but complementary patient-facing services. And we would be, is of great interest to us that there's continuity of services and clinical services for patients. So we're very interested in that. And so I think the simple answer is we have a policy setting now, which we're working with, and Jason can take you through what that is. But we are also moving to think about not wanting to disrupt clinical practice and clinical care, and making sure we're always evaluating and trying to walk that line appropriately.
And as you suggest, there's a lot of thought on this right at the moment. It's quite a critical juncture. So, yeah, we're doing a lot of thinking about this right at the moment.
I mean, I'm hearing some concern here. Would you, when do you think you'll be able to make a call as to a moratorium or not?
Well, I mean, there are other options besides a moratorium, but very soon, I would say.
We would like to be thinking what all the range of options are and what risks are and how you might mitigate those without coming to the landing on the right option right now.
And thank you, Mr. Chair. Just a few more. The other element of PHOs is a geographic place-based element, and one of the potentially disruptive changes that is occurring is more, let's say, nationalised rather than regional PHOs. How are you evaluating that change, and what's the potential impact of losing a place-based approach?
So at the moment, even if a new PHO is given the opportunity to have that contract, we still require them to hold a contract with one of the regional locations and not an overarching national PHO agreement. So while they may be one entity, they're still required to have a contract with the region.
But what does that mean in practice? Does it mean that they're actually grounded in that place and understand that community, or?
Correct. Yep. So they work with the region so they're still required to have a contract with, say, Te Waipounamu. So they work with the local regional team. They're closer to the community, and the regional team will work with that PHO on the services they provide to within the district. They may have their GP practice.
But then they'd have potentially, because they're national, have relationships with clinics elsewhere in the country, and there'd sort of not be any visibility of how well that PHO was integrated with the practices in that part of the country.
Look, this is where we come back to our planning and funding teams in the regions. That's a core part of their role, is we need them to be working with our PHOs, working with our general practices to ensure that they are connected to their communities. They've got their health promotion plans. They're working with their funding streams to ensure they're getting those services to the communities.
And my colleague just raised the concern around corporatisation and how that impacts PHOs. Can you just describe what you, the accountabilities that PHOs have to the community and how that's given effect to?
Yeah, so within the PHO agreement and then language of a back-to-back agreement they hold with the general practice via the PHO. There are a number of requirements in there, both clinical requirements, operational requirements, or across a number of the funding streams, so health promotion activity, services to improve access.
Oh, sorry, perhaps I should clarify.
Sorry.
That, like, what's the is there any specifications that their board must be drawn from the community that they serve, or have relationships with the iwi Māori Partnership Board, or what ties them to the community? Specified within the agreement, there are key components around the services to their delivery and what they need to do, about how they service their patient, register the services they're to provide, and we would monitor those through the PHO. So there is requirements in the PHO agreement and the back-to-back agreement about services that they need to be providing to their patient register is probably the way I'd describe it.
Hamish, so
Excellent. And it's probably along very similar lines. This is probably coming from a slightly different angle. What incentives are there for PHOs? And I think it was referred to as auxiliary services or complementary services. What incentives are there for PHOs to keep the general population, have good health outcomes for the general population in their region that they're serving?
Yeah, look, the PHOs are required to sort of have a population view and a plan against that for the communities which their general practices serve. And then within their funding streams, they have health promotion funding. So that's around activities to prevent or support health promotion within those communities. There's other funding streams that they will use to also around their planning, implementation of those services, and assure that their general practice deliver core frontline services to those communities. So there's a number of ways that the PHOs can do that. They can do that directly with the GP practices, or some of the PHOs will provide those services themselves, supporting a range of GP practices.
So we see a range of different delivery models across the country.
And that's quite appropriate depending on some of the communities they serve. While we want national consistency around expectations, we do want our communities and our general practice to be able to have flex on how they serve their local communities.
Excellent, thank you.
Aisha, did you have more sups on that?
I have one.
Jenny has a sup.
Is the PHO, when we have an expanded general practice, aside from the function of delivering the funding down to the practice level, is the PHO just a layer of bureaucracy? Will it become just another layer of bureaucracy, which actually holds up a bunch of money which could actually be put down through into general practice? Do we still need to have PHO?
Yes, we do have some.
I think to Dale's point before is it's work that we need to do with the ministry around PHO functions in the future. However, at the moment, a number of the PHOs through the country do provide services to our community across a number of practices. So there is mixed models, but it is work with the ministry that we need to undertake.
Dr. Vera.
I just want to return to ask for some assurance around the issue of disruption amongst PHOs and the service provision. Are you confident that there will be no disruption to PHO services based on decisions taken from here on?
We would be very mindful and thoughtful to be looking at those potential consequences that we might see, but we also think there's absolutely need for more policy work to be done here.
And will you be able to get visibility of the consequences of those decisions before you take policy in order to inform those policy decisions?
Well, we will be engaging with the ministry on that actively now to talk through that. And then some of that needs to be determined what's the policy decision of the ministry and the timeframes for that versus what's going on now. So it's a very much a live issue for us to be thinking about that right now.
Yeah, I mean, the PHO policy work was commissioned more than 2 years ago. I understand there have been changes in the people involved, but puts you in quite a tough position, doesn't it, to not have a policy framework at this point in time?
Yes, but what I would say is that even with the changes that we have seen, we've seen quite good. That's why we need to be so clear about the service delivery that we expect even with changes. And so going back to that PHO agreement, the list of services that we expect to be delivered to communities, none of that's changed. Back-to-back agreements haven't changed within that model. So I think that is absolutely one safeguard to that system. The thing that is of interest is just the degree of change there seems to be in the system at the moment, and also trying to understand what's driving some of that.
I think if I understand correctly, the risk isn't mitigated by the contracting, right? Because you could, a new PHO may say, yes, we'll be able to provide these services to, I don't know, 100,000 people or 50,000 people. Though that 50,000 will leave a PHO with only half the numbers of people in it, and the economics of running the services in the former PHO that they were in would then be very challenged. That's the issue, isn't it?
Yes.
Mm. Thanks.
Okay. I had a quick question around emergency departments, and it is one of the government's targets. And I note that we have seen an improvement of several percent being discharged or transferred within 6 hours. But my question's more around, you've got some high-performing EDs and you've got some ones that are not performing so well. So what are we doing, or what is Health New Zealand able to do to take those learnings from the high-performing ones and disseminate them around New Zealand to help bring everyone up a bit?
Yes, so we'll get Richard to answer that, but just frame it. We have seen an uplift in performance of the emergency department target, and that is also on top of a year-on-year increase in volumes, that patient presentations. So despite this last year, a 4% uplift in patients, and in some individual EDs, it's actually been a lot more than that. So it's not evenly spread. The health target has improved across the country. So we got to 74% in Q3, and in Q4, we got to 73.9, which is 0.1% short of the milestone, and no rounding, unfortunately. But there's a number of things there that has been going on. So one is exactly as you've described, understanding what's working well in large, doesn't necessarily need to be large, by the way. Some of our best performing EDs are in smaller provincial areas, but what's working well there, and how can we share and disseminate that through clinical groupings. We also have appointed an executive lead for the emergency department, which is Chris Lowry, who's based down here, who has a previous clinical background. Part of her role is to do that. Then we've had a $20 million investment, ED boost investment, trying to hear directly from the front line where to put investments. Some of that has been the separation of pathways. So when you come into an emergency department, if it becomes clear that you're not going to be admitted, you might go down now in some EDs at different streams, so that can be dealt with much more quickly, and then just straight discharge through a separation of patient streams. And then the other way is working with those streams where it does look like people are more complex, and then what's required to help speed that up. Some of it relates to workforce, and some of that means new investments in part of the workforce. There's also significant investment in some of the emergency department facilities, because some of those facilities are old, outdated, and also not very good for the models of care. So that's also in there. Another bit of that is access to diagnostics, because sometimes you can be waiting for a diagnostic. If you could speed up that access pathway to the diagnostic, that can help speed care. And then most recently, it's about innovation. And the emergency departments have been at the very forefront of picking up some of these tools, such as Heidi, where we've got over 1,000 now deployed into the emergency department. So they're very eager to use those tools. And then if you take it out of the hospital context, it's also the relationship with primary care. And are we able to, for example, in some areas, give advice about things that might not need to come to hospital, or give more options to primary care for them to be able to do diagnostics themselves instead of potentially having to send them to the hospital. So giving them a wider clinical access to things that might have previously only been in hospitals, that's also helped. So really that ED, although it looks like it's an emergency department issue, it's not. It's actually a whole of health system, how it's functioning issue.
I think it's a very thorough answer.
Yes, good answer. You mentioned around some of the tools that you're giving primary care to help diagnose so you don't end up in ED. What are some of those examples? Are they technology based?
Some are technology, but some are also access to diagnostics. So, for example, some clinics now are able to do point of care testing, so they might have blood tests actually there. So, I've seen that in a number of practices where they might be able to do cardiac troponin tests, for example, and they have ECGs. So, if you have that, you might be able to make the decision not to send that chest pain to hospital, because you can follow that up yourself in the practice. So it's having those sort of more advanced access to those diagnostic, and then it can be as simple as a direct contact between clinicians where you might want rapid specialist advice, and then a specialist being available to give that advice, and then you don't need to rely on being sent to the hospital for that advice to be given.
But you are quite correct that if you were just to have a look at a few of the ED departments that are struggling, if we got those up to just the average, the target performance increases pretty significantly. We should also mention that over the next kind of 6 months, we've got at least 4 or 5 locations where we'll have temporary ward facilities up and running. And these are places where we could actually move patients much more quickly because they won't bed block. So we have a number of initiatives, as Barry said, but we need to get to the point where the increased load doesn't keep deteriorating the position, for example, as we have in winter. So we're looking for a whole different model for winter as well. But there's a lot of options, but you're completely correct. We just deal with the 4 or 5 who's struggling the most, and we get a very significant uplift.
Thank you. Thank you for your answers.
Just to add as well, we've recently trained 16 primary care clinicians around point of care ultrasound, which is proving to reduce the use of either helicopters or people going into the ED as well. So they've been able to treat in the rural communities as another way of protecting our EDs.
Thank you. We've got primaries from Hamish, Ingrid and Asha.
Yes, excellent. And so we're going to change tack slightly to kind of planned care and also the surgeries. What advancements have been made in the elective surgery and maybe touch on elective boost to get through our wait lists?
So I might begin. So just as a background, our elective surgical waiting list reached all-time highs in January and February of this year, not previously seen in this country. 80 to 90,000 people waiting for elective surgery and nearly 40,000 people waiting over 120 days. We've been trying to make a concerted effort to bring those numbers down and give more people access to surgery. So there's a number of streams of work. So one is to increase the overall surgery that we're able to do. And in terms of our own hospitals, we have uplifted that this year compared to the previous year. That has meant work hospital by hospital, because it has to essentially be done theatre by theatre, so that we are able to now see across the country the relative utilisation of our theatres, the efficiency of those theatres, how we put our patients through those theatres. So we have a very good view about that now, which we haven't previously done. So it has been one of the advantages of Health New Zealand, that visibility, and then our feedback. We're able to go into feedback loops back to districts and say, this is what you're looking like compared to others as well. So that's been the first thing. The second thing has been a very concerted effort on our longest waiters and bringing those long waiters down. So being very thoughtful about who we're putting through the theatre list. And then we've also had partnerships with other facilities that are able to do additional theatres and lists for us, and we've had an elective boost where I think we were aiming for 10,567.
No, 10,579.
79, sorry, and then 16,000 was achieved. So we've absolutely been trying to use as much available capacity wherever that might be around the country. Finally, there are a number of in the public service. We have new theatres have come online, for example, in Auckland, Waitemata, Totara, Homaru, Counties Manukau, additional theatres about to come online, and also we have Burwood theatres as well. So we're very much thinking about the model of care in those theatres, and how, for example, in Auckland, specialists from other hospitals are coming to really focus on elective surgery and trying to have that separation of acute with elective, because the more you can separate that, that means we can have less interruptions to elective theatre, because it's dedicated just to electives. When you put them together, there's obviously some efficiencies about that at times, but there's also inefficiencies when you might get a very large increase in acute. So we're very much thinking about the model of care for surgery as well.
Excellent. So I take from your answer there's been an uplift of hospitals also using other facilities. You mentioned that the wait list was up to 80,000. Did I hear correct?
Yes,
Do we have an updated figure for what we're sitting on at the moment?
I do. So we have seen a decline. And so the peak for waiting for treatment occurred at 82,179 on the 12th of January. That dropped to 74,800 for this reporting period. And for those waiting over 120 days, it was around 37,000, and that's reduced to 27,000. So it's nearly, over a third, around a third reduced at 30th of June. So that's both the total and the long waiters reduced. But as you can see, we still have a very long way to go, because we were previously, as a health system, not having people wait over 120 days and having much more assurance that people would be seen within that time frame, and that is our aim.
Excellent. And I appreciate there's an emphasis to get those wait times down. Is it cost effective to use private providers for some of these surgeries?
Well, I hand over to Jason, who in fact oversees the program. I think there's several ways to answer that. We certainly go through a procurement process and a view about value for money, and also making sure they answer the specifications that we would expect. And so we do that. The second thing, with the scale of what has occurred in terms of our waiting lists, we need to use as much capacity that's available in the country to be able to bring these down. And we have always used other providers. In fact, we have just been looking at what is the relative percentage that we might be outsourcing. And over the last few years, it actually hasn't changed very much at all, that relative percentage. So the volumes are going up. The relative percentage hasn't changed in the last 2 years very much. So we've always had a need to use others, but the scale of the problem is large. And we have to use other capacity if we're to bring it down, because a lot of our public hospitals are close to capacity, and it's only these new theatres coming online that we get access to that. But I'll hand to Jason.
I think Dale's explained it very well. The critical factor here is reducing those wait lists first and foremost. And as Dale indicated, we go through a procurement process for our private providers to go through, and we get the best and most efficient price through that process. We bring it back to the patient, to the reason why we're using private providers through that capacity.
Effectively, the strategy is to optimize all of the available resourced capacity in order to increase our access. But we've got a real emphasis on internal production. We need to do more to get our internal production up, and we're doing that as well. So we should only be contracting out or working with partners once we've done our best on our internal production. So we're trying to work on all of these, but ultimately optimizing the resource capacity that's in the community.
I'm sorry, but we had Dr. Brandt here, who runs the Northern Hospitals, who would be able to answer at what he does at the front line around theatres.
So that's a good example about what's local and what's regional. So locally, we charge all the local theatre, all our districts, to actually obviously increase their performance. We monitor that very closely. We look at late starts, early finishes, for example. We have we have all these metrics that we look, and we look by every specific service and every specialty, and we actually have specific plans by district, by specialty, to try to get them down. Now, to actually show how the system's now working in the sense of regional, where, say, my role in supporting this is say we would, like in the northern region, meet on a weekly basis, all the people who are in charge of their local districts. We go through each other's performance, and we actually are challenging each other in that performance, and then share resources amongst each other. And that may be actually sharing theatres, it may be people, or we may be moving patients. And that's how at the region, we then also work on getting those electives down as well. So it's an example of how locally, yes, get on with it, and they need to understand by service how they're performing, but then regionally, we'd actually bring that up a level and actually work collectively to help get them down. And then again, I would meet with my 3 other executive regional director colleagues, and we will also meet on this issue as well. And we would also say, well, actually, is there something you're doing that we're not doing? And we sometimes will be shifting the resources, but it's primarily at that local level that we start at.
Just following the line of questioning around cost effectiveness, are you able to give us any figures on, say, comparative cost of doing it like Adam?
Please.
Yes.
Sorry, yeah. Sorry, I thought it was an interruption.
Ricardo.
Are you able to give us a figure on the comparative costs on average, maybe by type of elective surgery, doing it privately versus done within Te Patoora? And are you able to elucidate us a bit more in terms of that? And do you have any figures in front of us?
I need to come back with figures to the committee. I don't have that level of detail with me.
Would they normally be higher or lower?
I think it's a wee bit dependent. I'm making the assumption I don't want to do that for you. I need to provide the appropriate information to you.
What is the longest duration or length of a surgical outsourcing contract that Health New Zealand is in?
At the moment, we're largely out to the end of this financial year, June 30th.
What is there is a direction from the Minister to expand that. What do you think you're likely to do in the coming year?
I think working with our private providers, we do know now we need a certain level of activity through the private providers, and we're working with them now. But I think we'd need a contract length of 3 to 5 years to give consistency to the market.
Thank you.
Okay.
Primate?
I was just going to ask one, Luke. So in Tauranga, you've got Tauranga Hospital, and there's also Grace Hospital, which is a private hospital, but does a lot of surgeries on behalf of the public system. What would happen in my region if we didn't have Grace there?
If we didn't have it, just
If we didn't have Grace Hospital?
well, I think if we, as Dale explained, that's why we are working with the private sector, because certain circumstances and in some specialties, we just don't have that capacity. So that's why we need those relationships.
We'll have more people waiting longer.
Yeah.
Right. Ingrid Leary, primary.
Thank you. I'm trying to understand how the system currently promotes or stifles innovation. And I'm thinking specifically about the Whakamatutu Trust in Wellington, because we do know that the cost of putting someone through a depression service like that for a week at Whakamatutu is the same as one night at Wellington Hospital. We do know that the results of the ED wait times in Wellington Hospital are problematic. And in fact, Wellington Hospital wrote to the trust to say they would support a service. And we also know that having monitoring in the 3 months after someone has been through acute mental health is really important in terms of reducing their risk around suicidal ideation and so on. So the question is really, how is it that when something that looked to be effective and was applauded as a good innovation has not been able to be supported by our public health system, and on a value for money and a needs base for this type of service seems to make sense? What is it in the system that is preventing us from being able to fund these innovations?
Yeah, look, I'll actually build off, I'm not going to speak to the specific proposal from the organisation you talked to, but I am going to talk to Dr. Bramley's response, which is about, how do we improve and how do we take better out of what's happening across the country.
It would be useful to hear about the specific one.
Shall I keep my flow and then
Sure.
I'll come back? How's that? And then if
Thank
I don't
you.
cover it, you can ask me again.
Thank
Okay.
you.
So, how we build initiatives that are working well across each of the emergency departments. It's fair to say that Wellington is for the mental health ED target, one of the lower performing areas. What I'll say is that some of the characteristics, and again, Dr. Brand has touched on this in the emergency departments that we know are working well in terms of patient flow, are that there's good engagement with community organisations helping that flow through. Also that there is a strong interdisciplinary team between mental health and the ED specialists in terms of how they manage patients with acute mental health presentations. And also what we see coming through is actually the emergency departments that have got peer support specialists in them are actually starting to show some promise in terms of how they are adding to the mix. And the two examples I will use are Waikato and Christchurch. So the Christchurch ED has a very strong, good operating interdisciplinary team between mental health and the ED staff. Also have some good space in terms of where those people with mental health presentations can be streamed off and supported. In Waikato, again, a higher performing area, they have really good engagement and flow between the ED out to the community daily, sometimes 3 times a week, meeting with the community services to help the flow through. As this relates to the Wellington Emergency Department, they have a range of improvement initiatives, and this is also very much in the vein of Dr. Brent's response, where the Executive Regional Director is looking at what the suite of responses they need across that emergency department. So some areas in terms of their improvement plan are, which they have moved their crisis team closer to the emergency department, so that crisis team is able to respond to presentations more closely into that emergency department. They have also looked at how they might get flow out of their acute adult inpatient unit out to other alternatives in the community, but also have a number of other initiatives in place.
Can I just pick up on that? Because yes, you've talked clearly about the crisis response and appreciate that. The whakamatutu, as I understand it, is about recovery, and you've talked about the flow through to other services in the community. That's where the gap is, and that's where the peer crisis support, the crisis cafe has even said that they would work alongside because it's an and.
No,
So there is a gap there, and there isn't funding for something that can fill that gap.
So again, I'll park the whakamatutu point. We'll get to that. But again, I think you're quite right. There is good promise around the crisis cafes, and we're rolling those out across the country. So we're seeing people that would have previously turned up at the emergency department actually choose to go to the crisis cafe for support.
Yeah, but they're not
So-
a recovery service, are they? They're a crisis support.
No, look, all of the mental health services are part of recovery, right? So this is, people will present at many different points along their recovery journey, right? So absolutely the crisis cafes are part of that. Peer support and keeping well is absolutely part of the recovery journey, as is, to your point, ensuring that when people have been, had a more intensive level of care, that they are getting follow-up in the community. And that's why we monitor 7-day follow-up and 28-day, follow-up. And again, back to the Wellington ED initiative, these are the initiatives that that the ED has, that district and that region have put in place for the Wellington region to improve that target. Decision was made actually not to fund whakamatutu. It's not a provider we have funded in the past. And these are the initiatives that that the team are backing to help achieve the target. And they will continue, again, as Andrew Brent talked about, to review that if we're not achieving the target, then we'll look at what other initiatives need to be in place.
The second question I have, if I may, Mr. Chair.
You may.
And it goes back to outcomes, and this is something I continually do with psychologists, and is related but unrelated, is that we see, say, for example, with ACC sensitive claims, people with PTSD being referred to talk therapy or counsellors because we do not have the appropriate acute level of specialist service available. And they may do that for years in some cases with no measurable outcome because they have not gone to the right specialist. Where in the system are those outcomes being tracked in terms of people being referred to the right service for the right level of acuity and getting the right treatment?
Yeah. So look, so at our broader system-wide for mental health, we've got a range of outcome tools and measures, the ADOM, the HONUS and the HONOSCA for child and youth. So that tracks the measures across a number of domains. But as you get down closer to the clinical team, actually that's part of a multidisciplinary team approach where you're actually reviewing the care provided to an individual that sits within that multidisciplinary team. We're on a daily or weekly and sometimes monthly basis where they're doing case conferences, looking at what's happening in terms of that person's journey and whether they are receiving the right inputs. And that it's not just within the multidisciplinary team, but also more broadly to the NGO supports and other community supports.
Do you accept the concern from some of the clinicians that the right level of care is not being provided because of the workforce shortages, with all the best intentions in the world and with clinical teams, that at the end of the day, if someone presents at ACC, they can't get to the right service, so they're given counselling? These are some of the scenarios that I've been specifically told about. That feels like a workforce problem, and I understand there's a lot going on in the workforce space, but it doesn't really provide value for money if the treatment is not treating what needs to be treated. And in mental health, it's not as simple as you say, as kind of looking at someone's knee and going, well, they need to go to a knee doctor. So it gets a bit conflated.
Look,
would you accept that the workforce the crisis is having an impact on those outcomes?
Look, there's lots of different questions on what you're asking. But look, what I do accept is that everyone that comes to work in Health New Zealand, and particularly those that work in mental health, are absolutely focused on delivering the best possible care. And we are working to improve our system. We've got a range of interventions and new services in place.
we are tracking really well in terms of growing our workforce and the auxiliary workforces that we've talked about, particularly with psychology since 2023 to 2025. We've had about a 3% uptick in our number of psychologists. Yes, I think there's more work that we need to do between ACC and mental health, recognising particularly people that have complex trauma around what is the right stream of where to get support. And I don't think the system has quite got that right. But but again, back to my first response is that people are working really hard and sometimes in quite pressured environments.
Absolutely acceptable. Thank you.
Excellent. New primary, Dr. Vera.
Thank you, Mr. Chair. I have a set of questions about public health. The committee and anyone with a parliamentary email address has a lot of questions and representations made about prostate cancer screening. Can you give us an understanding of how you are evaluating the benefits of prostate cancer screening and what role you see for it in the public health system, if any?
Thanks. We haven't yet developed a view on prostate cancer screening. I'm aware there is some interest across the board. I'm aware that the evidence is very conflicting around the value of that. And I'm aware that certainly from a public health perspective, the evidence is not as strong and that much of the interest is around various advocacy groups, and also we are aware that the Cancer Control Agency, Te Kahu, has asked to have a look at that. So that's as far as we've taken that so far.
Oh, thank you.
Dr. Vera, there is a historical backdrop to the question, of course, too. And in earlier times, the National Health Committee, when it put out its screening criteria, specifically looked at prostate cancer, and at that point said there wasn't sufficient evidence for a publicly funded screening program. Since that time, there have been updates and reviews of the evidence, and I think it's been very much in the opportunistic piece rather than a population-wide screening program. But what I would say to that as well is that in that function, you have to continuously be updating and re-evaluating the evidence to then determine, have we met a threshold that might have changed that view and decision? Because, as you know, it's always about the balance of the harms and benefits of a nationally organised screening program. But we, as Nick's saying, we need to be vigilant about that dynamic of evidence and being open to reviewing the evidence.
Yeah, that's fantastic. And we had a petition earlier in the year, and in the submission, an official submission to the petition, we were told a review is underway. Can you give any update on that? A review of the evidence for prostate cancer screening?
I'm not aware of a review by Health New Zealand. I am aware that the ministry are looking at some policy around that as well.
Policy on whether or not it's...
I think they're looking at the review itself, and certainly not aware of Health New Zealand conducting a review at this stage.
So back to your comment, Dr. Bramley, about remaining vigilant, where is that function of reviewing the evidence sitting at the moment?
Yes, so we would see that the national question, so we would be able to provide technical expertise, public health expertise, epidemiological expertise into answering the questions. The policy decisions of a national screening program part is led by the ministry, including the development of a national case.
Yeah, this isn't a
around
question about when are you going to do it, but we're getting requests from members of the public, and we want to understand where do we go to cite the right evidence that's gone through a proper process. And
we will get back to you on that. I'm sorry, I don't know.
Okay. Thank you. And, you know, screening has the potential to vastly improve people's health. What opportunities are you looking at in expanding the range of conditions that can be screened for?
Yes, and absolutely. I mean, both screening has a huge opportunity to enhance health and prevent cancer and other conditions, but of course also if not carefully evaluated, can do more harm than good. So we are looking at bowel cancer screening and age extensions, further age extensions to that. We're considering that. Also looking at lung cancer screening. In both cases, there are very good evidence for those. They have very big price to them, and so we are just looking at the evaluation of those at the moment.
Can you explain why bowel screening is so costly when there's an expected reduction in the number of colonoscopies that need to be done because of the fit symptomatic pathway that's recently been rolled out?
Yes, so the fit for symptomatic pathway hasn't been fully rolled out yet. We are in the early stages of rolling that out. The evidence for fit and what it can achieve is anything between a 30 to 60% reduction in the number of colonoscopies required. However, the UK experience actually was an increase in colonoscopies as they put the fit testing through general practice. So it varies hugely internationally, and we haven't got any really good evidence on the impact on Māori, Pacific, etc. with that program. But we do expect as we roll it out, it will reduce our colonoscopy waiting lists.
Well, isn't there the opportunity? Sorry.
Sorry, I just, there is a nuance also that screened patients tend to have significantly more polyps found if they're fit positive. So lowering the screening age in terms of costs also includes the histopathology. All that needs to be factored in.
And the length of the colonoscopy itself is quite significantly longer because you've already selected out.
Yeah.
Okay.
You've already selected out the population by them being fit positive through the screening program, so they are at a higher risk than those who are symptomatic.
Thank you. Can you describe where your plans for implementing lung cancer screening are?
Yes, so we've been doing some work on that and evaluating the program and working our way through considering whether over the next year or two there would be able to be a lung cancer program, screening program. So there's a lot of work going on evaluating that at the moment.
What is the lot of work?
Pardon?
What is the lot of work?
Well, it requires a full business case. It's an awful lot of money. It requires treasury input.
Do you have a view on the design of the screening program that is optimal for New Zealand?
Yes.
What is it?
It's based on smoking history.
So, and how long ago should people who have stopped smoking be before they don't need screening?
I'm sorry, I can't answer that.
All right, we have a primary with Dr. Campbell.
Excellent, brilliant. And probably touching on a little bit of the previous section, but probably broadening it out past cancer. What is Health New Zealand's current assessment of population health trends and which interventions make the biggest difference over time? And it may be, I appreciate it may be some of the interventions you've just mentioned.
Just for our exam question.
Feels like it.
Does feel like I would start by saying if you look at the sum of mortality, morbidity, it goes to life expectancy. And we started the presentation by saying New Zealand actually does fairly well by life expectancy, sitting at around 82 years. And then if you look at the major causes of mortality, there's still cancer and cardiovascular mortality, both of which have seen fairly significant declines in recent decades. Some of that decline is now starting to level off, and so as some of the gains in life expectancy. And we've mentioned too the difference between different population groups, in particular Māori, the life expectancy gap was 8, now it's 6 years. But again, some of that's now leveling off as well. So I think you could say we've had a high degree of success around reducing amenable mortality. So that mortality which we can prevent by suitable interventions of the healthcare system. we've still got a bit of a way to go. We're also seeing modern advances in medicines too, especially in oncology, which look like they will make quite significant differences to individual tumour and cancer streams. Then if you look at the risk factors that might cause ill health, we have seen some very significant decline. So for many, many years, the leading modifiable risk factor influencing ill health was tobacco smoking. And we have seen the significant decline of that. So we're sitting at 6.8% as of the very latest survey. For Pacific, just over 10, and for Māori, around 15 to 16%. So we still have gains to be made there. Then you've got an amalgamation of other risk factors which are moving. So obesity, and there is some debate about definitions of obesity and healthy weight, as it were, but obesity rising. Obesity is absolutely a risk factor for a number of diseases, in particular diabetes is of concern for us, and we are seeing rising numbers of cases of diabetes, and that impacts multiple different conditions. So that would be an area we're concerned about. And then in terms of other risk factors, in particular diet, the foods that people eat, exercise, that cluster of things become very important as well. What I'd say in terms of access to health services, it's of concern that we have, although it's improving, there is still significant access to services issues. So in primary care, as we've seen, we've still got 20 to 25% of people having difficulties accessing, and then we have very long waiting lists. So then in terms of our actual treatment services, we're seeing improvements for sure, but there's more to be done. So, and then finally, what I'd say about health outcomes is that they sit within a wide range of socio-economic determinants as well, and your access to those things, for example, disposable income affects the food you buy, and degree that you might have education to get a good job and all of those things. So it's sitting within that cluster as well. Overall, I'd say New Zealand's doing well compared to where we see ourselves with other countries, but we know where we might need to continue to intervene, both at risk factors, but also in treatment services.
Is it brilliant? Because where I was angling with, I appreciate it's quite a big question, is really what Work is Health New Zealand doing in the health promotion space to actually people can live well, so they don't actually need Health New Zealand services.
Great. Well, that's a much easier question for
Yeah,
Nick.
I think Dr. Bramley's passed his public health.
Yes. We'll give the
actually.
gold star.
Yes, so there's a lot of work going on in the health promotion space, and particularly we're focusing on mental health promotion, and we have a program around alcohol and promoting a number of initiatives around reducing alcohol intake. There's also cigarette smoking and tobacco. We're working on that. We also provide quite a significant program of promotion around our immunisation programs, measles more recently, and also all of our other screening programs. So we're working through a whole lot of areas. We fund significant programs around green prescription, active families, a number of healthy action programs, and certainly physical activity is an area where we can get really good health gains from. And so we do work promoting that as well as work around healthy eating. And so a lot of different promotion initiatives. We also, within the alcohol space, are working with sports groups, and over 20 of the various rugby unions at a second division level are now involved and looking at their sponsorship and reducing the sponsorship on alcohol.
Excellent. And of course, you did mention about immunisations. And there has been a great uplift in our vaccination rates. What challenges do you still face when it comes to immunisations?
Yeah, so I think we'll call it vaccine hesitancy is our biggest challenge, and particularly in rural areas and high Māori communities, and to a lesser extent in Pacific families. So that is where our biggest gains can be made, and that's the real challenge around getting some of those communities, particularly post-COVID, but even before that, to trust us again.
Excellent, thank you.
All right. Ingrid Leary, primary.
Thank you. It's just a question around some of the numbers that we see being discussed, like 82% of people are seen within 3 weeks, getting referred to specialist mental health and addiction services. I'm trying to reconcile that with the recent health survey data that showed that 1 in 10 adults said they were not able to access mental health and addiction services over the last year, and 1 in 4 young people mentioned experiencing serious levels of mental distress. So wanting to test the veracity of the number, and when I look at how that 82% is made up, the Mental Health and Wellbeing Commission has said that the overall use of specialist services has decreased over 5 years, so fewer people are accessing services. And that's particularly true for youth. So we're not seeing overall access or unmet need being addressed. And I'm wondering whether you see that statistic of 82% as statistically relevant, or whether it would be more meaningful. Are you collecting the data on those who are not being referred for other reasons?
Look, there's quite a few questions there, Ingrid. I'll do my best to step through. So, look, what we've seen overall from our mental health and addiction system is actually for the last between last year and this year is actually an improvement in access. So in terms of the individuals accessing our mental health system, we've actually grown from 178,535 in 2023-24 to 184,409 in 2024-25. So that's a 3.3% increase. When you get down into the detail for youth, so we've actually seen an increase for youth across between the 2 years, where there's been about a 14.9% increase in access of numbers accessing our mental health services. Also, what we've seen across our primary access and choice services is an increase in numbers actually accessing those services. Okay. So the first part of your question was around numbers accessing. So we've seen growth in that. That doesn't necessarily go to where the need might be in the community. And I think I answered earlier, that's why the Ministry of Health are doing undertaking or committed to undertake a prevalence study to understand where the need is and whether we've got the settings right across the system.
Thank you. So is there any way of capturing the number of people who are not being referred because GPs, for example, know that the services are not available? I take your point that the prevalence survey should be able to answer that, but in the interim, what I'm hearing from clinicians is that a lot of referrals are not made because the services are not simply there. Therefore, the 82% for me seems to be counting a subset of need rather than the true requirement, and seems rather disingenuous. So that's really what I'm trying to test here.
Look, I think if I had it my way, I think 100% of people that have need and access, would access services when they need it. I think the two targets around wait times actually give us some answer around whether those are getting the response. So that's based on, from point of referral to receiving that first contact and first assessment. So on both the primary care mental health target and also the secondary, the 3-week wait time for secondary services, we're actually seeing improvement.
Are you counting the declines as well? Because that's another piece that's not
So we do look at the declines. Right. And also, clinically as well, in terms of how the service operates, is that people, and particularly this is for hospital and specialist services, is that people aren't just declined without a pathway to go to. So people may be declined and asked to go back to their general practice in terms of getting access and choice services, and also the range of other support services that are there and available.
And where can we find that data?
So we don't track the data in the way that you're asking that question.
Would that be useful? Because then wouldn't that give us a more complete picture of of access to services, which is what we're talking about?
Yeah, so look, it could be useful, but it's certainly not something that we track in the way that you're asking us. Yeah.
Thank you.
All right, Jenny Mark.
Thank you. Palliative care, I think I mentioned it earlier. Just wanted to circle around and do a couple of quick fires on that. No specialist palliative care in hospital in Whanu. Is there a funding issue there? Also, how many FTE specialist palliative care inside Health New Zealand? And assisted dying FTEs inside Health New Zealand, have those numbers?
I deal with the wider palliative care
Yeah, sure.
picture at the moment, and then which can go into a wee bit more detail. So we've got quite a significant focus on palliative care in this system within New Zealand because there are issues in delivery. So we've recently had the paediatric palliative care out for consultation, which closed a couple of months ago. We had over 1,700 pieces of feedback on that. The adult palliative care model was out recently, and that's just closed. So our teams will be going through that feedback as well. And both of those aim to be paediatric early next year, with the adult being a bit later, based on that feedback. We're working heavily with Hospice New Zealand and hospices throughout the country on a funding model review and information review from hospices to Health New Zealand to better allow us to make good decisions. I think one of the legacy issues we've had, so for example, in hospices with 20 DHBs, we've got a very different funding model, very different access criteria, very different service requirements in that palliative care. That also includes residential carers that are important as home-based support services. So if we look at the bigger picture of palliative care to start with, we've got those three key pieces of work underway at the moment. Hospice should be finished around June next year, and the outcome of that is a more consistent purchasing framework and more consistent funding framework for hospices. So we know, and hospices know, what the expectations are. We can be better informing our communities around that. Alongside that is the two palliative care reviews around adult and paediatric models of care. So a lot of work just in the overall space, and it alludes a wee bit to the specialist palliative care service we can provide, both from a hospital, but really looking at a community-led model. As you can imagine, the paediatric feedback was heavily focused on families and communities being able to access closer to home, less travel, but that doesn't necessarily mean you need a specialist at every point. It means about how do we access that and how does that get put into their model of care, working with the general practice and the local community to support those families.
So that piece of work around palliative, there's three things coming out: the hospice work we're doing, then the paediatric
and the adult.
And when will that all be done and dusted by?
So we'll release the feedback on the paediatric early next year. So that will go back out to communities, which is going through the review process. The adults just closed, that will be later next year. The work we're doing with hospices, we're hoping to have that complete by June next year.
Yeah, I think with hospice, particularly, everyone probably has a hospice in their community. They were able to access lotteries funding. They're no longer able to do that. So it's really put a bit of pressure on what they're able to provide for their communities.
Absolutely. So, and we're working with understanding, because it's become, not blurred is the wrong word, but the hospice shops funding, the lotteries, or whatever grant funding they could get in, donations, and what is funded through Health New Zealand. So this is intended to get really good information. So all the hospices in New Zealand are feeding in that data, and we'll receive that and then work with Hospice New Zealand on that.
Great. Look forward to that.
All right, we've got 10 minutes left in this segment. We don't appear to have any more questions, so I will suspend us and we can come back at 3:30 and we will do health infrastructure.
3:30. We're not getting a 15-minute break.
Yes.
The break. update my Instagram.
With what?
Send
FYI.
Yes, yes, it's all right. It's all right. They know who they are.
Yeah. Maybe Kevin, yeah, maybe next to go.
It's one for the space here.
Hey, David on David first and the website. Yeah. We're not at the
Bevan, you're in the box seat.
Scotland.
All right, so we have 2 hours to go. We've got health infrastructure, asset management and investment, current state of hospital infrastructure, update on key projects, digital and data. Aisha.
Thanks, Mr. Chair. I'd like to ask about the Health Digital Investment Plan. Thank you for publishing this plan. There are many ways it's quite informative. I'd like to talk about page 10 of the plan and on which it includes this pie graph. And I wondered if you could explain it, and am I correct in understanding that it means of the investment, 28% will be directed primarily at achieving improvements in the clinical and operational experience?
Yes, that's correct. So in terms of the modelling, there are obviously interdependencies between those areas. So clinical is dependent on infrastructure, for example. But in terms of the primary focus of that investment, that's where the primary focus goes.
So the technology is 45%, and that, do I take it, that reflects the current state of hardware and software and the fact that that doesn't have sort of an end user benefit, but must be done. Nearly half the investment will be just in the tech.
Yeah, correct. And that's the reason why in the plan we talk about stabilisation, modernisation first. So if our foundations aren't solid, and today they're not, then modernising the application, clinical application estate isn't going to improve performance and give you the value you need.
So then that's the 45%, and then 28%, those are the big wedges in the pie. So the thing that's a little concerning is that only 2% of the benefits are likely to be for the people and whānau experience, 2% for intelligence and insights, and 10% for digitally enabled models of care. Why are those ones carry such small weights?
So firstly, the percentage is about investment rather than value. So I think if you look at infrastructure, if you look at supporting clinical service delivery, then they do have flow-on benefits into people in whānau, and clinical, for example, includes population health. Digitally enabled models of care leverages off of that clinical investment as well. So the reason those are lower is simply because we've got significant underinvestment and current issues around our clinical and our infrastructure estate, which we have to address.
So we can't up the benefits to enable digital or new models of care until the technology is addressed.
It's a mix. So predominantly, yes, there's a lot of future digitally enabled models of care benefits that we can't realise without those foundations. There are, of course, opportunities. So there's always opportunities to leapfrog and leverage some of those modern platforms to be able to put digitally enabled models of care out there quicker. A good example would be some of the work we're doing on remote patient monitoring, where you can actually use that technology to deliver care out in the community. You're not reliant on existing infrastructure or existing integration with our clinical systems. So it does depend. But yeah, we've got significant legacy, complexity and challenges around our current state.
I wanted to go to the point 9 on population health, which is, sorry, it doesn't have page numbers. The action items under population health seem very focused on the most important specialty, which is infectious diseases. However, long-term conditions could also benefit from a population health approach enabled by data, and in fact, they are far more common in terms of their health impacts than infectious diseases. So why are infectious diseases prioritised instead of long-term conditions and chronic disease?
That's a good question. So primarily because of the investment needed in that space. So we work very closely with our population health colleagues, clinical colleagues, in development of the roadmaps. What we do have in the population health space, which is probably a reflection in the investment need, is we do have pretty good modern population health platform capabilities that support our screening programs, support our sort of health promotion activities, and we're leveraging those. So relatively speaking, there's less investment needed in those, which is probably why that picture is a bit skewed. But I mean, the roadmaps are it's a 10-year roadmap. So at a point in time, this is what it looks like in terms of our governance and oversight. Those roadmaps will be continually refreshed. And I would expect to be guided by population health function as to where the priorities lie and to respond to those as they change. But yes, good question.
Do you think we have the ability to identify? Do you think the health system has the ability to identify people who need interventions to prevent cardiovascular and diabetes, data-enabled mechanisms to do that and find them and help them?
I think absolutely. If you look at our ability to leverage data, and if I think about our response to something like measles outbreak, we're doing a whole range of things.
Sorry, my question is about chronic disease. Like in the working age population, there is still a considerable number of Māori and Pacific people who have early mortality due to cardiovascular disease. And what I'm trying to explore is why that isn't prioritised, because this is the 10-year plan for population health and there's no action on that. Seems like a problem for me.
Yeah, that's a fair comment. I defer to my population health colleagues. I mean, certainly leveraging data is a separate roadmap. We'd expect to be looking at data across that as well.
Right. Maybe one of your population health colleagues will step forward in a minute. In the meantime, I wanted to turn to the other area that looked relatively light, which was the primary care, element 10. I mean, there's only 2 items for investment over the 10-year period in primary care. And one is support the sector to modernise primary and community and enable access to virtual GP consult. I mean, that seems pretty low ambition for the part of the sector that the population interacts with the most.
Yeah, so the first item there is significant, though, would be my comment, that at the moment we have real fragmentation and challenges around what, of course, is a public-private mix of the sector. So what we need to do in that roadmap is work with primary care to understand what the requirements are, and then through there define what the specific target areas are. What we know today is that we have data that is locked up and not able to flow between different primary and community agencies. We know that there's some challenges around the age of the technology, particularly in general practice. So we need to work with those organisations and work more broadly on what a more detailed roadmap looks like.
Who wrote the plan?
So it was written by Health New Zealand. We engaged with clinical networks. We engaged with the executive regional directors and their teams to build up the roadmaps. And then underpinning it is a financial model that allows us to flex and refine the plan as we go forward.
It was entirely written in-house?
It was entirely written in-house. The one area that we got assistance with was the financial modelling. So the financial modelling that sits underneath the financial profile was developed with the help of a third party.
Getting close to the end, Mr. Chair. And the cost of delivering this plan, have you costed it yet?
We know the cost. I don't have the number in front of me. It was predominantly internal resource, though.
You mean within baselines?
Yes. So that the only cost that wasn't included in baseline and was additional cost was the use of that one third party.
And is this, so this, are you saying that the entire 10 years of work is now funded?
No.
I think it's interpreted your question as the plan itself.
I'm
Yes.
sorry.
I think the question is the
Right.
cost of delivering the.
Oh, sorry.
cost of
So the
delivering-
cost of
The cost of the
developing plan?
PowerPoint slides. yeah.
Okay.
It was otherwise very good news, though.
This is right. No, so apologies, misinterpreted the question.
So tell me about what you know about the cost of the plan over the 10-year period.
Yeah, so we've modelled the cost of the plan based on the roadmaps and the assumptions. There is no secured funding to deliver the plan. What we do know is that we need to fund from a number of sources. So we need to look at ways to prioritise within our digital baseline. We need to look at ways to prioritise within Health New Zealand's baseline.
Yeah.
And we need to look at where additional funding is going to be needed. We also need to look at how we engage differently with the market. So we know, and certainly over the last 12 months, we've engaged differently with some of our technology providers and looked at different ways of delivering capability. So all of those things need to be explored. We will do that on an investment case by investment case basis. So every investment here needs to be articulated and then justified and approved through a standard business case.
Just to clarify that in that case, does that mean you're not considering offering to one vendor various different contracts which they might tie together and offer you a better deal? You're not going to look at that approach.
We will look at any approach that allows us to deliver the technology capability we need and can optimise the value, but we'll do that through standard government procurement rules. In some areas, we will want to simplify and standardise onto common platforms. In other areas, we want to enable innovation and we want to enable the market to respond in different ways. So all of those options are open.
And important to emphasise that this is a 10-year plan. There is more detailed work to do to define the precise scope of these, just like for the health infrastructure plan as well. As we do that more detailed work, I think opportunities like the one you point to will come to pass. And we will also need to look at the phasing of that to unlock those opportunities as well. And that's the work that Darren and the team are going to be leading.
So I think one of the other comments to add is that we, in announcing the plan, we also released on government tender service a signal of market intent, because I think one of the challenges we've got in the absence of a plan, the market has had to be very reactive. They're not quite sure what we're going to buy and when we're going to buy it. And we tend to go with individual tenders rather than it being part of a considered plan. And that's one of the reasons why we've got such a fragmented environment and why we really struggle to successfully deliver at scale. So the intent of the plan, I think, is also to inform the market of direction of travel, where we're heading and what's coming. And I think that's really important.
I actually didn't want to convey the sense I was encouraging of the option of packaging up. In fact, I hear from New Zealand firms quite often that they feel locked out of procurement opportunities. And anyway, that's that. Can you give the committee an estimate of the type of commitment annually required to sustain the plan?
So
deliver the plan?
Yeah, so we've modelled that. We know that if we look at proportionally, so we know that in our current investment trajectory, we invest about 2.8% of our operational revenue. International benchmarks for that and health sector investment are between 4 and 8. One of the questions is how do we reprioritise and how do we secure that funding? Because we don't have any headroom. We have to remain sort of fiscally responsible. So part of this depends on the pace at which we can move. So we are working with our internal process. And we're working on our go-to-market and our investment case development to try to get those investment cases as quickly as we can. But we need more funding than we currently have, that is for sure.
Yes, up over here.
Excellent. What are the next steps for the implementation of this plan?
So we're we are forming a centre for digital modernisation of health. So that, if you like, is the engine room that drives delivery. One of the challenges I think we have is that when you try to deliver plans like this, which are pretty ambitious, and when you try to deliver those at scale and you try to do it out of your business as usual structures, it is really challenging. So step one is to get the centre set up. Step two is we're working on standing up our delivery structures. So unlike traditionally the way you do this, you would write an investment case and then you would get investment case approval and then you would stand up a structure to deliver that. We are standing our delivery structures up first. So we have delivery portfolios with business or clinical sponsorship and leadership, and they will develop the investment cases. They will make sure the roadmaps are robust, and then investment cases that are approved will drop into that delivery structure. And then the third thing we're doing is looking at our go-to-market. So in terms of how do we engage with the market around our priorities, what are those priorities and how do we do that in a robust way? In some cases, we can leverage existing partnerships. So I talked about population health would be a good example. So we have a platform and we have an industry partner that we already work with. There's new capability available on that platform that would provide real opportunity to deliver value into population health. That is a good example of where we think we can, there's a really solid investment case and we can move fast. In other areas, we don't have the capability or we have multiple vendors and we need to go to market through a contestable process and decide how we move forward.
One of the other really key next steps, and it probably links to questions, is we're going to need to understand what's the capital expenditure here versus operating expenditure. As you are aware with the accounting rules, a lot of digital investment has moved under the SaaS rules to OPEX, and that will be really important to understand. It's probably one of the things that we need to work on with Treasury as well. I'm sure it's not unique to Health New Zealand, this challenge. And if we're to unlock the benefits of digital, then ensuring our funding models reflect the importance of that investment and how it flows into OPEX, I think would be critical.
I think that's a very good point. You've got one more start and then Aisha has a start.
Where in the priorities does the National Electronic Medical Record sit? And I appreciate you talking about leveraging existing tools. Bearing in mind I'm an MP from the South Island, and of course we have Health One. Where does the National Electronic Medical Record sit in the priorities?
It's absolutely a priority. One of the challenges with it, though, is that in terms of where New Zealand is starting from, and in terms of what you're seeing internationally, some of the traditional descriptions of an electronic medical record or an electronic health record or a patient administration system, they're really blurring. So when you think about the power of data, the ability to apply AI for workflow, the clinical user experience, the ability to provide channels out to people in whānau in terms of engagement in their healthcare. What we need to do, I think, in terms of that domain as a priority is we really need to think carefully about what are the outcomes we're looking for and then actually engage the market to understand what capability is there and where should we start. I talked about leapfrog. I think this is one of those areas where we probably shouldn't assume that we can just build on something we have. I think we should carefully look at where we invest. You'll see elsewhere in the document we talk about an independent data layer. So I think the separation of data from application is really, really important. We're seeing impact of things like Heidi, which Dr. Bramley mentioned, real impact on clinical user experience, cognitive load. These are the sorts of things I think we need to look at carefully before we make a decision about what we might procure. But it is a game changer.
But I think it's fair to say in the shorter term on interim, we are leveraging technologies we have. So we have a system that was built within initially Whatu, And we've got other hospital areas, other districts that have nothing. They're still on paper. So we're now actually implementing that in those. So for example, Waikato, Taranaki, and Health One. That's got a lot of utility because all of this will take time. So we don't want to wait until we get some mega system. We're working to use what we have, leverage that, get that into places that don't have anything in the meanwhile so that we can just speed things along. I think also to your point earlier, Dr. Burrell, that the thing is with these platforms, they are quite adaptable and there's quite a lot of utility. And once we've got them in place, you've got the licenses, you can actually shift your population health emphasis or add. So it doesn't, just because it's not a list, it's not excluded. And actually in this kind of system, the cost of including is relatively low. So we have to be open to that. So I think that this is a sort of framework more than every specific. But once we've got these platforms right, then we can build on them quite easily.
I think it's a really good point about building on what we've got. So we take the product that Lester mentioned. We also have electronic prescribing. We know we have many of our hospitals still using paper. We actually have a nationally selected tool that is being used successfully. We need to deploy that. We shouldn't wait. We have a national maternity platform, again, being used by both hospital and community. Midwifery, we should be rolling that out. So this is a sort of an and conversation. We need to be looking at what the future would be and then carefully think about how we procure it, while at the same time rolling out tools that we've got that we should be scaling.
I think Dr. Campbell, Health One that you mentioned, which has been in the South Island for quite some time, has now been rolled out into the North Island quite rapidly. And Tora Compass is going up to the North Island, and there's 4 PHOs in the North Island to join up with the South Island PHOs to expand that product quite rapidly. That's actually happening right now.
And it'll go national.
Excellent. Good to hear.
Dr. Vera, so.
What assurance can you give that key parts like the electronic health record will allow the product that's purchased or built will allow interoperability with other tools?
It's fundamental.
Fundamental.
So I mean, if you look in the investment plan, we outline in that sort of data and interoperability domain, we talk about the need to really enforce data standards, about the need for interoperability, and part of our challenge in New Zealand is that with the fragmentation we have, information just does not flow. The modern platforms that we need to implement, interoperability is just a given.
Just fundamental.
What can you say to vendors in, the smaller tech startup vendors in New Zealand about the opportunities they would have in that?
Well, the great thing about these modern platforms is that all of the modern platforms that I've seen and looked at recently, they enable this ecosystem of innovators. The days of locked-in platforms, I think are gone. We're seeing real openness now around the ability to innovate on top of platforms, and also, of course, leveraging AI means you've got to have access to the data, and that's a really key part of the design.
Just to conclude this area, Mr. Chair, the earlier question about population health, if Dr. Chamberlain has anything to add on that.
Yes, that work stream's referring to a number of activities. One of them is the shared data platform that we are developing, which will allow us to access general practice data, their population registers, and the coding of that, as well as our own, to help us understand cardiovascular disease risk assessment data. We're also looking at developing My Health Record, which is the patient portal, which will allow patients to take more activation of their own healthcare.
All right, very good. Thank you.
Okay.
Mr. Chair, can I raise a point of order? I just don't want to disturb anyone, so that's why I just raised it now.
Point of order, Dr.
Yes,
Chan.
I just want to remind everyone that December scrutiny, we're supposed to look back at the past 12 months, not looking into the future. So I just want to make sure my colleague will focus on a question which is on how
last 12 months the government agencies have performed rather than looking at what they're going to do in the next 12 months.
Yes, that is true, but it can have a bit of.
But I try not to
intent to it.
disturb anyone, so. Yeah.
Primary.
All right.
Beryl.
Well, noting that in the annual report, you mention health infrastructure. Tick. So thank you for publishing this infrastructure plan, but I have to say it's much harder to understand than the digital plan. So can we start with a high level description of what is in scope for this plan, what is out of scope, and the funding commitment required to deliver it?
Roger, do you want to start with that one?
So the plan was put together by the infrastructure group in the last Relation of Health New Zealand, and quite a comprehensive plan. It was built around standardising the build processes rather than doing everything differently each time, building hospitals better. Two fundamentals: the acute services block, standardisation around the Australian standards of the acute services blocks, and also standard wards. That was published, and we're working actively with that. So Whangarei is progressing rapidly. The work started. It started on acute services block. We're also considering the need for wards as part of that. So I think it's a moving plan that, having identified a particular issue in a region, that it can be moved and developed, and having approved and going ahead with the acute services block, subsequent reviews looked at, is that enough? Do we need wards? Nelson, likewise, another key part of the health infrastructure plan, is down there with Dr. Margaret Wilshire a couple of weeks ago, looking at that, and that again proceeding at pace. Other areas we looked at is that while we're looking to build an acute wards, some of the needs have become more apparent. So for Palmerston North, again with a visit with Dr. Margaret Wilshire, yes, a need to rebuild the acute services block and inpatient units, but the local GDO there has said actually I need more urgent action, and the team has turned its attention to more urgent action in terms of ICU, ED, CT, and beds. And so, having identified the large plan, we're refining it in terms of clinical need. And I think one of the things we've learned over the last 2 years is that with the centralisation, that we might have lost contact with some of the clinical need locally. And so the plan is being refined, but still the speed with which it's being moving at is considered as continuing, and it is moving at pace.
Page 8, right, it's got 4 stages, but the text indicates this is a 10-year plan. This is all of the building hospitals investment. So you've got 10 hospitals listed here and multiple projects within that. So that plan, is that all work currently underway? Business cases done or approved, or?
Business cases in development, the Auckland refurbishments, those plans are business cases for stage 3 going ahead. Whatu, business cases going ahead.
Sorry to interrupt you. I don't expect you to list from memory, and we can written questions about that. But I guess just what I'm trying to get is
yes, moving ahead with Dr. Burrell with pace, and the minister is very insistent and supportive of driving ahead with these initiatives, and the funding is flowing with those.
Is it fair to say that a decision has been taken that if your capital project is not in this plan, it's not happening for the next 10 years, barring some new evidence about something being an urgent priority?
I think it was a plan that was set out for 10 years, was said we are starting to look at priorities within it that, so for example, the portable wards that have been built, there's $100 million for portable wards, urgent need for beds, free up ED. So it is a living document. It is being varied, capable of being varied. But the overall intent of the remediation, particularly for the regional hospitals, is still very much on track.
And how the annual review documents note a gap between the capital funding and the funding required to execute the plan. Can you inform us what the funding required to execute the plan is?
The current year, we're looking at our capital expenditure plan is $2.8 billion. That has been funded by our own depreciation of $980 million.
Yeah, sorry.
And $2 billion
I'm just asking what's needed for the
capital
plan, not what the current budget is.
I'll let you answer this question and then I'll go to Cameron.
There is the funding has been laid out and the requirements for that. The immediate funding, as I said, the $2 billion, the $980 million, and going forward, those pathways are in place.
It's probably also.
Sorry, just
So I was just going to add that look at the total projects that we've got underway, whether they be in defined delivery, etc. We've got $7.6 billion of projects underway. And it's very similar to the digital plan. As we get into the specific projects and we look at the scope of those projects, we may find opportunities to do things more cost effectively. And so
I think if I could just explain the motivation for the question. Infrastructure, it's a 10-year plan. As members of Parliament, we need to take our responsibilities to cost our proposals about health capital seriously as well. Therefore, being open and the cost of a plan that you're hoping to extend beyond political cycles is just something that helps facilitate good decision making. So has this, that you're able to tell me the digital plan required 4 to 8% of the health budget to be spent on digital. So is there a similar figure for the capital?
There is not, because, as I say, particularly for the regional hospital redevelopments, if you think of Hawke's Bay, if you think of Tauranga, or if you think of Palmerston North, those are very involved projects. We're defining the clinical scope and therefore the infrastructure that is required needs a considerable amount of work. Once we've done that work, we'll have a far better idea of the cost of those projects. I'd also note that Whangarei is another great example. There was an original scope that was put up. It was too expensive to fund, and so the team has done excellent work to rescope that ASB project, bring it within the capital available. And that's actually what the plan is intended to do as well. You set out the priorities and the focus areas so that we can ensure we get value for money in the investments that we make.
Cameron.
Nelson was another good example of that. The original scope that was put up was very, very expensive. Working with clinicians there, it's been refined and come in at $790 million current budget, and that's been approved and moving ahead at a pace with that. So it is being refined from concepts to actually what is deliverable, but the intent certainly with the regional hospitals, it's moving at pace.
Okay.
Thank you. I'm interested in talked about these standards and this building hospitals better program idea that you're running. These buildings standards, is this to get away from variations that see blowouts across, as we have seen throughout our infrastructure when it comes to building new stuff? And how have these standards that have been developed, who were they developed with? You said New Zealand, Australia standards, and how have they impacted on what you've done so far? And I think you talked about Whangarei. So can you talk about what these standards have actually done to bring everything into line to make sure we know what we're actually building?
David. Yeah, ask David, who's our head of infrastructure, to talk to that.
So the standards are using Australia and New Zealand national standards so that we get a rational base. Allows us to do two things. One is to internationally index what's needed, but also allows us to get some standardization across the country. Second thing we've done is actually applied those into a modular base so that the module can then be refined to meet a specific requirement. So the requirement in Whangarei may be slightly different from the requirement in Nelson or Hastings, but the module that's small enough can be used to duplicate that for size, scale and application. And the third thing it allows us to do then is to reduce the cost of delivery, because we don't have to go back to preliminary design every time. We can use the model and the standard designs and then simply apply the additional design requirement for the site-specific piece. So the seismic requirement may change, but the fundamental functionality of the design doesn't.
Sure. And are these modules, which I take it a module just means a package of plans and specifications that you need to be built to, are these modules accessible to the market, say? So someone who might want to take an opportunity to develop a piece of medical infrastructure or healthcare infrastructure that could potentially be used in the future by Health New Zealand or come to process. Are these modules available outside of Health New Zealand?
At the moment, there's standards that the standards are available internationally. And so anyone can take the standards. We've developed them with our clinicians to meet our requirements specifically around each of the areas. And that's then formulated to set the basis for the procurement model, which is then costed through.
Sure. Thank you.
Thank you.
Other questions?
Primary questions. Okay. Do you have no more subs on
I
this?
have one more sub.
So,
Why does the plan have more specificity on the number of car parks than the number of beds?
I'm not sure that it does.
It does, because it has a list of car parks with the number of parks that will be in them. And then all these hospitals were building, but no list of the number of beds.
Most of the plans I've seen specify the number of beds in ED, the number of beds in a medical ward, number of beds in ICU, etc., as part of the criteria. So we can provide you with more data if you want more data. The car park one is probably the most simplistic because it's square meters divided through when for a flat piece of blacktop.
okay.
It'd be great to have that information.
Supplementary,
Is
Cameron?
it the case that when building infrastructure in New Zealand, especially buildings for humans to occupy, there are set building code standards that define how many car parks you need in district plans that also do that?
There are car park requirements that vary slightly by jurisdiction, but predominantly our car parking requirements are driven by our own requirements for meeting the needs. We know Whangarei had 400 odd car parks. With the growth, we know we need more, so we're putting in a facility for 500 odd. That ties in with the growth requirements and the known utilisation and demand. It's not a statutory requirement by the Northland Council.
Well done. Dr. Verrill, guns down. All right. Primary.
Thank you,
colours.
Mr. Chair. My question, a very quick question. I just want to get an update on how the Auckland Hospital upgrade going.
Yeah, third one is finished, came in under budget. That was the first remedial. Third two's underway and third three's just been approved. They've been very successful projects and there's a lot of learnings. A very, very, very talented team at Auckland with the consultants and the engineers successfully delivered that and remediated a 1960s building. Third two is underway, third three's just been approved, and we've got very good knowledge now of the engineering required and the costings. That model's been rolled out across other parts of New Zealand to Whatu, and that knowledge will also be extended to parts to North where we're doing urgent remediation.
So my question is the hot water pipe being changed now?
That is part of the part of Auckland and has also been looked at in terms of Waitemata to the copper pipes. Yes.
There are 3 stages to that replacement in Auckland. We've completed stage 1, and just a month ago we signed off the 2nd stage of that plan. The point Roger makes, it's one of the important benefits of Health New Zealand, and given the success we've had in that FERP program in Auckland, you look at the other upgrades that we've got to do nationally. We had a question earlier in the day about learnings. I think it was with regards to ED. We can now flow those learnings into other parts of the country, Palmerston North, for example.
We're certainly aware of the copper pipes now and the need for maintenance and timely replacement of that, and that's being looked at with copper pipes from Waitemata.
Yeah, so is there any temporary work being done to address those issues in the past 12 months?
There's various amounts of temporary work being done. The key one that we're working on at the moment is Palmerston North. There's $180 million been approved for Palmerston North and remediation projects for electrical and in particular fire, where that building's been left for a long time, and urgent work now underway with 3 packages of work, so $180 million.
So how about Auckland City Hospital?
That's continuing. That work's been underway, as Bevan said, and it's been approved. And FERP 3, 3rd stage of it has been designed now.
Any more questions from members?
Are we moving on to the general section?
There is always room for a general section part of this. Do any members have a general question, current event or other issue they want to raise or ask Health New Zealand?
Yes, Mr. Chair.
I do.
I do. Primary questions.
Right, go to Hamish.
Excellent. Given this is an annual review, has the delivery of healthcare services in New Zealand improved since you were last here from the committee?
Yes.
Do you want to elaborate?
Yes, is good.
Yes, it's good. It's good. All right.
Across multiple dimensions, but
I'd say multiple domains we are seeing improvements. Access to services and the number of people being seen and being able to treat is absolutely rising. Primary care has had significant investment going in, and we're seeing a number of our indicators which relate to health outcomes are starting to lift.
I'm sorry about that. Hasn't worked all day.
Merry Christmas.
But we absolutely have ongoing challenges and a lot of work to do, as indicated by the lists, significant waiting lists that we have and waiting times, and also the need to keep building up our staff and culture.
and improvements are good and welcome, but they're nowhere near what we want to achieve. So we've got a lot of work to do to still get there. I think what's probably the most pleasing out of what we see is the recent increases in productivity, because that's really important for us to be able to enhance access.
Good point. Dr. Campbell, any more stuff?
No, that's good.
Okay.
Thank you.
Dr. Chong.
Thank you, Mr. Chair. I think I asked a similar question last year, but I just want to follow up. After 12 months, I still receive a lot of complaint from the hospital staff that there's a lot of medicine and device wastage in the hospital, and we haven't addressed it. So what is our approach? Like, I give you a little bit example. A lot of, from what I heard, a lot of blood sugar testing machine devices are being chucked in the bin, unopened, but just because they're expired. How can we address the issues to minimize the wasteful spending in the hospital?
We might get Dr. Sullivan to come up and answer that, but we do, in terms of wastage, you could view that as underuse or overuse or misuse, right, in terms of a classification. What we'd say is that for some things, we know that there is some overuse of that, so we try to build in systems that might be able to give feedback loops that say, for example, you might not need that blood test, or that might not be indicated, or we remind you that actually you've had that test done recently and you don't need to do it again. You can also put in additional layers. If you think something requires a higher level of, scrutiny, that could happen. And we're also using things like our clinical networks, where we're saying to them, for example, and radiology has just come and presented to the ELT, what are some of those procedures now that might not be clinically indicated that we do, for example, x-rays for? There's a series of things actually then may not be of use. And then we're trying to put in guidance around how to stop doing that or to minimize that in terms of clinical practice. And then I think you're getting to very much right on the shop floor is their wastage. Well, I mean, that's partly a culture for us to work with our teams and staff because every resource that we have matters. And if we're misusing it, then we can't use it for patient care.
Yes, obviously, this is on the management level. How about on the recycle level? How can
Yes, I was going to say,
recycle?
we do have a sustainability program, and I don't have the details at hand, but with clinical leaders as part of that, interestingly, actually often led by anaesthetic specialists, because they see a lot of wastage through the theatres.
That's right.
The packs come in, they're only partially used, the syringes can be recycled as plastic and so forth. So there's quite a lot of single initiatives going on, but it is one of the opportunities within the kind of construct of Health New Zealand whereby can we scale that stuff. So there is a system, we do have a sustainability function with clinical engagement, but I don't have the exact details on hand. But it's exactly as you're saying, that people are seeing the opportunity to really to rethink the way we use things. So you can bring more information back.
All right. Hopefully, we're not asking that question next year. So yeah.
Or we'll have a
Thank
better
you.
answer.
Hey, thank you, everybody. Dr. Bramley, Professor Levy, Dr. Connolly, Dr. Sullivan, everybody else. Thank you, Bevan, all the officials, clerks, MPs. We are done for Scrutiny Week. Your review 25. Thank you.
Thank you very much for having us.
I want you more.